Duchenne muscular dystrophy and its impacts on the endocrine system. What is Duchenne muscular dystrophy? Duchenne muscular dystrophy, or DMD, is a genetic mutation that occurs on the X chromosome. This mutation leads to a shift in the reading frame that prevents the functional formation of the dystrophin protein. The lack of the dystrophin protein increases contractile damage and muscle degeneration in those who have DMD and other forms of muscular dystrophy. Because it occurs on the X chromosome, we see this disease occurring mostly in males, with the prevalence being 1 in every 3,500 live male births, with the age of onset usually between 3 to 5 years of age. Now you may be wondering, what is dystrophin? Well, dystrophin is one of the longest proteins found in the human body, measuring approximately 427 kilodaltons. It is associated to a glycoprotein complex found in the sarcolemma membrane, interacting with various other proteins. The dystrophin glycoprotein complex helps with the protective properties of muscle in order to prevent the muscle from having contractile or force production damage, which is important in relations to movement and force production and living our daily activities. Some symptoms of DMD include frequent falling, trouble running and jumping, waddling, walking on toes, and having large calves. Although these are the symptoms of DMD, the only way to properly diagnose an individual with DMD is through a muscle biopsy and through genetic testing. What is the endocrine system and what effect does it have on DMD and treatment? The endocrine system is a series of glands that produce and secrete hormones that the body uses for a wide range of functions. These control many different bodily functions, including metabolism, respiration, movement, and growth. Hormones are sent into the blood system to the various tissues in the body. They send signals through these tissues in order to tell them what they're supposed to do. When the glands do not produce the right amount of hormones, disease may develop that can affect many aspects of life. Popular treatments for DMD include steroids. However, it is important to look into the effects of steroid treatments on the endocrine system in order to allow the patient to have a homeostatic endocrine system.
As was mentioned before, there is endocrine dysfunction or endocrine dysregulation seen in boys with DMD, some of which are exacerbated by or are a result of glucocorticoid treatment. Beginning with metabolic abnormalities, for patients with DMD, there is an increased risk for obesity or weight gain. The very nature of the disease limits the options for physical activity, and there is existing confusion on the benefits or harmful effects of muscle training for these boys. It is this decreased mobility or the reduced energy expenditure that plays a factor in greatly increasing the risk of weight gain and obesity. Additionally, the use of glucocorticoids also increases the risk of weight gain due to its role in increasing appetite, fluid retention, and the changing of fat mass and redistribution of this fat mass. Therefore, obesity prevention and management strategies should be prioritized, especially since biological adaptations make losing weight that has already been gained increasingly difficult. Apart from the social isolation and stigmatization of overweight and obese children, boys with DMD are at a high risk of insulin resistance and type 2 diabetes, both of which are also weight related health complications. Another common endocrine effect seen in patients with DMD is growth failure or short stature. Although newborns are normal length, they have a slower than expected growth velocity in their early years. And although the growth velocity eventually becomes age appropriate, they remain at a below average height percentile during childhood and adolescence. The etiology of growth failure is still unclear, especially since growth hormone secretion remains normal in patients with DMD. But there are several potential reasons or mechanisms as to why there is this growth impairment. Some studies suggest that early poor growth concurs with a period of extreme muscle necrosis and regeneration. Also, reduced physical activity, decreased bone turnover, and lower bone loading may also contribute. Additionally, there may be some genetic contributions, such as the deletion of the short stature homeobox gene, which plays an important role in the growth and the maturation of bones in the legs and arms, since a copy of this gene is located on the X chromosome. Also, it's interesting to note that patients with DMD who have a distal deletion have a higher frequency of short stature. Lastly, a major culprit of growth impairment in boys with DMD is the use of glucocorticoid treatment, since exposure appears to induce chondrocyte apoptosis at the growth plate. Other effects include delayed puberty, bone loss, and adrenal insufficiency. Delayed puberty is characterized by the absence of physical manifestations of sexual maturation. In glucocorticoid treated DMD patients, this is due to hypogonadotropic hypogonadism, which results in testosterone deficiency. Delayed puberty can also have secondary effects, such as negatively impacting psychosocial development and self esteem. It is important to note that some studies have indicated that boys with DMD who are not receiving glucocorticoid treatment or therapy tend to progress through puberty appropriately. Alterations of bone metabolism in patients with DMD result in a reduction of bone mineral content or a reduction in bone mass and a reduction in bone mineral density. Within the first year of glucocorticoid treatment, there is about a 6 to 12% bone loss, with the fracture risk increasing rapidly within the first 3 months of the treatment. Additionally, there is also the possibility or the consequence of glucocorticoid-induced osteoporosis. Lastly, patients with DMD who receive high doses of glucocorticoid treatment suppress their hypothalamic pituitary adrenal or HPA axis. Therefore, it is imperative that these individuals be trained in emergency response to and appropriate management of adrenal crisis should glucocorticoid therapy be stopped suddenly or in times of severe illness or injury.